Okay, and hopefully everybody can see this. Right, so just a bit of housekeeping, as well as very kindly already mentioned. This meeting is recorded. It's so that if anybody hasn't been able to attend, they can catch up with it afterwards. Please do mute your microphone unless once we get into the questions and feedback, and then obviously it's different. Do pop your questions into the chat as we're going along. It's not a problem. I've got my colleagues here as well who can pick those up for you and either answer directly, or we can bring it up as part of the discussion. This is meant to be interactive. Please don't be shy. Make your voices heard. It's a two-way process. There's no right and wrong answers in this, and hopefully we'll all benefit from it. So as I said, today we've got two case studies, one around cardiovascular disease, one around respiratory. The discussion and questions will be ongoing right throughout the two case studies. And then, as I mentioned earlier, we want to give you a brief update on the red bridge lipid pathway pilot. So let's just crack into it then. We have case study 3. This is following on from the previous case studies that we've done. So we have a female patient, 47 years old, Bengali ethnicity, 3 children, 26, 24, and 11. They work as a health advisor, as a 111 call handler. Works shifts 5 days a week. They've been type 2 since 2011. They had gestational diabetes in 2010, hypertensive since 97, peripheral artery disease diagnosed in 2019. They have mild kidney disease. They suffer with high cholesterol, and they get migraines, which are triggered by their menstrual cycle. No known drug allergies. Okay. So here we go. So in terms of their repeat medication, so they're on ramipril 10 milligrams, amlodipine 10 milligrams, lansoprazole, indapamide, zolmitriptan, sitagliptin, gliclazide, metformin, aspirin, and atorvastatin. On their acutes, they've got gluco-RX test strips, lancets, paracetamol, and they've been double jabbed with their COVID Pfizer vaccination. So here's some investigations for you. BMI 32, kidney function EGFR 77, creatinine 110, potassium was 4.7, and their urine ACR was 1.2. Nothing unusual in the LFTs apart from the ALT, which is raised at 77. Blood pressure done recently, a little bit on the high side, 154/92, 158/89, 149/88. Pulse 91 regular, HbA1c 62, lipids, total cholesterol 6.2, LDL 5.1, triglycerides 3.2. They were not fasting when they did the blood test, and their diabetes eye screen showed no abnormalities, no retinopathy, no maculopathy, and their foot check in August was fine as well. So they're here with you for their SMR. Never drunk alcohol, never smoked. Family history, mother and father both type 2 diabetic, both with blood pressure. Father had a heart attack at 77. It was a non-fatal heart attack. Brother is also a type 2, had a stroke at 55, is a heavy smoker. Home blood glucose monitoring, they haven't got anything to show you because they don't normally do it. In terms of physical activity, does walk 20 to 25 minutes every day, twice a day to the train station. Work is stressful, often has to do late shifts. Is a carer for the husband's parents, they live with them. She has a Q-risk 3 of nearly 27%. Was on insulin whilst pregnant, and had preeclampsia during the 3rd trimester, had very high blood pressure. Always takes their medicine, apart from the odd occasional missed dose. Metformin is giving a lot of trouble, has done MR as well. As soon as she takes more than 500 milligrams twice a day, starts getting cramps, wind, diarrhea, and from EMIS, it looks like the patient is taking their medication. Upon questioning with the patient, having your chat, bit miffed because the zolmitriptan's always running out. Also now concerned about the zolmitriptan because somebody said, you know, that migraine tablet can cause a stroke and it can cause a brain tumor as well. So she's a bit, okay, is that true? Also having problems with the diuretic, needs to go for a pee more often. Yeah. Okay, needs to pee more often. And when she's doing shift work, that can be a problem, especially if you're on a call and need to go. Says she's got a good diet, eats lots of fruit and veg, but has a lot of white rice, is unable to really cut it down because it's the staple in the family. That's what everybody wants. Mother-in-law did have COVID in March, was hospitalized, and that proved to be a very stressful period for her. Husband's not vaccinated, doesn't believe in COVID. It's a bit of a man-made thing, doesn't want to get jabbed, thinks the vaccine's out to kill you. So, next steps. What do we need to do with this patient then? And let's go back to, where would you like to go back? Tell me. Anybody who would like to kick off? Any immediate things that you've picked up from this? Anybody? A lot of silence. Rima?
Unmute myself. So her Q risk is high. I'll start with the obvious.
Okay.
So we could start there. With what? Sorry, I missed the blood pressure. Did you have?
Blood pressure was 154.92, 158.89, and the best was 149.88.
So we'd want some home monitoring of that, because if we're looking at her holistically, getting her blood pressure and her cardiovascular risk factors are probably more important than tackling her diabetes at the moment, because your cardiovascular risk increases with diabetes anyway, and that's what normally kills people with diabetes. So that's what I'd start focusing on first. Okay, I'll let other people jump in.
Yeah, who else would like to jump in terms of any of this Q risk and cholesterol and blood pressure? Who would like to have a go? Come on, don't be shy. I think they've all muted and having sandwiches or something. Come on, anybody. Is there anything that strikes you or over and above what Rima's already said? Do we have a look at the medication?
In terms of her triptan, is she using the triptan? Is she saying it's running out all the time and it can narrow the blood vessels with constriction? That might be increasing her blood pressure, because she's saying it's running out all the time. So if she keeps using that, her that might be causing her blood pressure to be bumped up slightly, which isn't good.
Possible.
So it might be something to think about.
Absolutely. So for her triptan, she's got to take it 2 or 3 times a day on the days a migraine is expected.
Yeah.
Or from 2 days before and until 3 days after the bleeding starts.
Yeah, it's
so that's very specific, isn't it, for her period migraine.
Yeah.
Can you see why she's getting annoyed though? We're only giving her a pack of 6.
Yeah.
So a good point around the vasoconstriction. What about, does the triptan likely to cause her a brain tumor or a stroke?
I mean, with the ischemia, if the blood pressure goes high enough,
Yeah.
I mean, it's going to be related to her blood pressure. Then yeah, if it goes high enough, then yeah, she could get a stroke if it's persistently high blood pressure. And I mean, if her blood pressure is uncontrolled, that's something to be wary of her triptan anyway.
Yeah. So actually, it's really important, isn't it? Because if she does, if we stop the triptan, what's likely to happen?
There's no parents with her if you just stop the triptan.
Right. Well, if we stop the triptan, she's going to end up with migraines, right?
Yeah.
Or potentially worse migraines, which will knock her out, and she won't be able to get to work. And do you think she'll get more stressed?
Yeah.
Yeah. So vicious circle here, right? So somebody else, tell me what can we do with her medication? Is there anything we can do with her medication?
Optimize her atorvastatin.
Okay, who said that?
Tahira?
Hi, Tahira. Yes. What's wrong with the atorvastatin dose?
We noticed that her total cholesterol was 6, so she could go higher. So we could put her on 40.
Okay.
But we were worried about her ALT, so just want to see if it was fatty liver or something else going on with the liver.
Mm-hmm. Okay. So how would you do that?
Will she need a scan?
Possibly, yes. You'd want to see what the trend is, and maybe have a chat with the GP, and just get a screen done for the liver, maybe an ultrasound done just to double check it is fatty liver. What other kind of questions?
I was going to say,
please.
sorry, I don't know what you do in practice. This is actually quite interesting. This came up only a few days for me. So if I see raised ALTs, I'm assuming, because of the whole metabolic picture, we've probably got a fatty liver or stenosis in the liver.
Yeah.
But I think our GPs prefer to refer to hepatology, just do the scan, but just refer the patient on. They, especially if you're saying, a trend. So irrespective, we tend not to ask for the scan. We just refer to hepatology, and they request the scan and give us their final thoughts, and then we manage it from there.
So slightly different in the practice that I work in. They will send for an ultrasound and find out if it's fatty liver or anything else. They might do a hepatitis screen at the same time. Anybody, do you think it's important to do, like, whether it's talk to the GP and get the GP to send off for a hep screen and a scan, or do you think it's really reasonable just to do nothing and just say, look, she's got BMI of 32, she's got high cholesterol, she's a diabetic, it's going to be fat in the liver? Who would say, you know what, that's what it is, and so we don't really need to do much more than that? Anybody?
No, I'm of the other opinion. You must investigate it.
Who is that?
Me, Rima.
Rima, so we know what you do. I'd like to hear what anybody else have a different view on that and think, well, it's pretty obvious looking at this, it's a fatty liver.
Yes, we've had a similar case in my practice, and I did discuss it with the GP, and he had said most likely to be fatty liver, so nothing further was done at that point, but recheck, so review in about 3 to 6 months' time, just to keep an eye on it.
Fair enough. Anybody else? Well, that's to add to that. Okay. So I think, personally, I think you do need to investigate it. And the reason is I know of one case, not involving a pharmacist, of involving a medical practitioner, where the ALT was raised and patient did fit your typical fatty liver scenario. It turned out to be cancer. So, and it got missed and it didn't end well. So for that reason, well, not just that reason, but you just don't know whether it is fatty liver or not. If I was to put money on it, I'm not a betting person, but if I was to put money on this patient, I would say it's not hepatitis, it's not CA, it is almost 99% fatty liver, but it's that 1% chance. And this is why you as clinical pharmacists need to raise that. And Nishma, you did absolutely the right thing. You raised it with the GP. Then at the end of the day, it's down to the GP to decide how they're going to manage it. But as clinical pharmacists, it's our job to raise that issue. Okay. Brilliant.
By the way, before you leave the LFTs, would you not be looking at the other liver tests as well and looking at the trend as well?
Yeah, absolutely. So you could look at the trend, but you could also get things like the GGTs done as well. You could look at the ALK false and all of the other stuff. If it's an isolated ALT, as I said, it's most likely going to be fatty liver, but get the GGTs done as well. Yeah. Get them sent off. You'll get a better picture. You might want to get the AST done as well. But ultimately, you know what? It's about working within your boundaries. And I think I would, yes, we can do that. And I do that. I do send off the bloods, but I will always have that discussion with the GP. You have to have that discussion and document you've had that discussion. Then they can decide scan or whatever.
Yeah, Mohammed, I was just going to say, LFTs, when you order them, are not ever just reported as just ALTs. It's a suite. The gamma glucotransferase, you do have to order as an extra, but I would only do that on a repeat LFT that are abnormal in the first instance. But then if you're going to look at LFTs in more details, you would also look at your clotting screen as well. So you'd order PT and INR as well to see intrinsic liver function as well.
I totally agree. Just nobody raised the point that they would look at the other tests and also look at the trend. It hasn't been.
Absolutely. Excellent.
Since nobody's offering, Imran, I think let's start with BMI as well. That's raised, and are the diabetes medicines the ones that are going to tackle that BMI? So a review of the diabetes medicines to look at the HbA1c and to look at the BMI as well.
Yeah, because it's at the end, it's a structured medication review. We're looking at everything. So here I mentioned about increasing the statin. So let me ask a question. What dose of statin should a patient who's had a end-STEMI heart attack be on?
80.
Chocolate bar for anybody. Go on then.
80.
80. Okay.
I don't get a chocolate bar, do I?
No, you don't get a chocolate bar, and you're not going to answer the next one. What if they had a STEMI heart attack? So an end STEMI is 80. What about a STEMI heart attack?
80 milligrams as well.
Yep. What if they've got angina?
80.
80 as well. 80 as well. What dose should they be on if they've got peripheral artery disease?
80.
80.
Yes, atherosclerosis, 80.
Yes. So what dose is this patient on?
20.
20, yes. So ideally, this patient should, if they've got a diagnosis of peripheral artery disease, more than likely they were started off on 20. There might have been an intention to titrate it upwards. Look back in the history. Were they ever on a higher dose? Did they complain of muscle ache? Did they complain of side effects? did their ALT shift upwards when they started the statin? So we need to investigate that for this patient. So assuming that the ALTs have never been more than 3 times the upper limit, always been floating between 40 and 70, and they were started on a Torva 20, who would up titrate straight to 80, or would you go to 40 and then consider 80? What would you do?
I'd wait for the liver screen first.
Okay, so we wait for the liver screen, and the liver screen to come back, and it said fatty infiltrations.
And I want to go guns blazing as long as she doesn't mind.
You want to go to 80?
If she's not had any issues and she has never been on a high dose, then I would rather go to 80, and then if she doesn't get on, then drop it to 60 and then 40 and work that way. Because I find up titrating statins a pain, because invariably it never happens.
Okay, good. Does anybody want to do it differently?
Yeah, Imran, I would definitely go with 40, because again, those same NICE guidelines, which suggest 80 milligrams, do have the proviso that in multimorbidity, which this very much is, that you can be a bit more cautious on the dose of statins. So I would definitely go with 40.
And would you just leave them on 40, Mohammed?
If they were getting on okay, we would consider the 80 with a shared decision making.
Okay, all right. So if this patient, let's say we put them on 80, came back and said, oh, you put me on 80, I'm getting muscle ache, what would you do? How would you investigate?
Tell them not to take it for a few days and see how it goes. And then
Yeah, you can do that.
I always retry. I give them a week to come off it, see how their muscle ache is, and then retry. Then I think about.
Anybody else?
Could you do check the creatine kinase levels?
Yes, you could. You absolutely could. You can check their CK levels and see how they're getting on. How many of you would maybe give them a little holiday and then restart the statin? Is there any evidence behind that?
Me, I do that a lot.
Yeah. Anybody else?
I do the same, Imran. I give them a few weeks off and restart it.
Yes, and there's evidence behind that, isn't there, for statins, that sometimes when the patient does develop a bit of muscle ache, if you stop, you give it a few weeks off, you start, and often they're okay. So there are some trials and studies around that, so you can Google those. So that it's definitely an option.
And would you start it on the same dose? Oh, sorry.
Yeah. Well, you could. You could go back into the same dose, or if you wanted to be cautious, maybe you go in at 40 and then titrate up. I think Rima's point is that as long as there's some follow-up and you are going to titrate up, then there shouldn't be an issue. The issue is you start off on 20 and then you forget about them. After how long starting the statin or increasing the dose of the statin should we be looking at monitoring liver function and cholesterol? Should we give it a year?
3 months.
3 months, well done. Yeah, let's check again after 3 months. Need to make sure it's working. Are we worried about the triglycerides? They were 3 point something, I think.
They weren't fasting when the test was done, so if we were worried, we could retest it whilst they were fasting.
Yeah, so exactly, and it's not terrible, but yeah, if you're not fasting, often you'll see raised triglyceride, and it can be raised quite a bit, you know. And then if you're concerned, just get them to repeat the full lipid profile, but make sure they are fasting this time. All right. So
because this patient is also because the patient is diabetic, how do you go about fasting blood tests in diabetes? Is there a particular, would you say, okay, it has to be done in the morning? Or I've never really
Nearly all fasting bloods are done in the morning. They normally get first appointments, don't they? Well, they do in my area.
Yeah, it's BHR isn't quite as accommodating, but remember this patient's not on insulin. Okay, and if they're going to be fasting for that day, what's their medicine? Which is the medicine that's going to cause the problem?
The glycoside.
Okay, so why don't we just tell them, look, the morning that you're going, just skip the morning dose of the glycoside. One dose of glycoside skipped isn't really going to be that much of a problem, is it?
I see. Okay.
And they won't have a hypo. They won't have a hypo. Go and get your blood test done, and then just carry on as normal in the evening. That's actually a brilliant Adiba, that was, wasn't it? Well done, because that is real life scenario, isn't it? About going and get your fasting blood glucose done. And if the patient, for whatever reason, does take the glycoside, they're going to end up with a hypo while they're waiting for their blood test. What about in terms of managing their blood pressure? They're already on max dose of ramipril, already max dose of amlodipine, and they are on a diuretic. What would you do?
SGLT2?
Okay, who said that?
Tahira.
Okay, Tahira, yes. So we could consider an SGLT2. What would you do? Just add it onto the sitagliptin and the glycoside and the metformin?
Potentially you could, because it's insulin independent, but you might want to just take off the sitagliptin and you could add it on, and it might make enough difference to the HbA1c that way.
Would you stop the sitagliptin? What about the glycoside? Maybe we could, would you want to reduce the dose of the glycoside and add it in?
Oh, yeah, sorry, yeah, half the dose.
Yeah, so we could do that. What is one of the problems that this patient has in terms of how the sitagliptin, sorry, how the SGLT2 might work? They're already having a little bit of a problem. This could complicate things.
Yeah, passing urine, she's having a problem with, isn't she, regularly? So that would make it more frequent.
Yeah. And what other kind of side effects we might get with the SGLT2?
She has a higher risk of UTIs.
Yeah, absolutely. So she's already peeing a lot. She's going to be peeing even more. The SGLT2 has an advantage in that the systolic blood pressure will come down a little bit. But is there a risk in doing that, that actually she ends up with UTI? She passes urine more often. She gets caught out of work. It's becoming annoying, and therefore just stops taking them. It's something to think about. I'm not saying you can't do the SGLT2, but I think that's where that shared decision making with the patient comes in. If we explain it and say, look, potentially, and then just say, look, what do you want to do?
It'd be good to also choose an SGLT2 that's got renal benefits. Canna Declan, one of those two, because of her proteinuria as well.
She's actually all right. She's A1.
Oh, did I?
1.2.
Oh no,
Yeah.
did you not have the proteinuria up? I thought it was above 3. My bad. I may have read that wrong.
Yeah, no, it's okay. That's one thing she's, believe it or not, despite everything, she's got no complications at the moment, thank goodness. So yeah, but yeah, if they did have proteinuria, obviously you would want to try and go for one of the CKD proven SGLT2s.
Imran, perhaps this is just this is maybe advertisements from the industry, but SGLT2s, perhaps it's not. It's a more even extra urine production through the day, and perhaps not so much causing problems, or is that just? industry speak.
That is true. No, that's true, Mohammed. And I would say that most patients I've spoken to, I would say probably 60–70% have not said to me they have any problems, but there is definitely a 30–40% who have literally stopped taking it because they're passing urine, and some of them were bus drivers, some of them were minicab drivers, and they were like, no, I can't hold it in. So it has caused problems. But again, it's an individual response. This lady may well be okay. She may well be okay. In terms of the thing is, we do want to try and control that blood pressure, and SGLT2 would be really good. Who's brave enough to look at that sitagliptin and tell me what potential, considering it's got BMI of 32 and is South Asian, what else could we give instead of a gliptin? Who would like to, and reduce their cardiovascular risk at the same time?
A GLP-1?
Yes, absolutely. We could be thinking about a GLP-1. Do you think having an injection potentially would be a problem for this patient?
Doesn't say she's needle phobic.
No. What happened when she was pregnant?
Gestational diabetes.
What was she on?
Insulin.
Insulin. Thank you, Aksa.
Welcome.
She was on insulin. So that's definitely a discussion you could have. It's going to have cardiovascular protection. It may help reduce the weight, and it could just be the thing that takes the HbA1c into less than 58. So again, it's an option, isn't it? And if she loses weight, maybe the blood pressure might be a little bit easier to control. Possibly. So
Would you
a lot of things there. Go on.
Would you think about tackling perhaps shift work? Because we know that shift work also happens to increase our cardiovascular risk and diabetes risk as well, because it ruins our circadian rhythm.
Yes, it certainly does. And it's a known fact that people who do shift work are more at risk of getting diabetes or poorly controlled diabetes. Just a fact. And even the blood pressure. Because you as Rima said, you know, your hormones are all over the place. How can we help her with that, Rima?
So normally I'll discuss whether she could perhaps, well, I'd ask if she's able to change her shift patterns, or but actually there's no proven way, as far as I know anyway, to actually reduce your risk that's related to your sleep patterns. But as keeping your sleep patterns near in terms of your daylight hours as possible, and like awake hours during your daylight hours as possible, is the best way that's proven. That's what the latest research shows. But
so could we, as an intervention, could we speak to the doctor about maybe writing a letter?
Yeah,
their occupational health, and say, you know, this may be having an adverse. Is that an option?
That's an option, but obviously this is an ongoing discussion with the patient. Because if the patient chooses to do shift work because it fits with her lifestyle and pattern, because of her care needs and whatever of her family, then that's always more tricky to address. If it's not dependent on the employer, but more the patient. If you see what I mean.
Yeah.
So,
yeah, but it's definitely something to consider, isn't it?
Yeah, definitely. I never understood.
What has anybody got anything? One final thing, then. What can we do about that blood pressure? So we've looked at maybe changing some of the diabetes meds, which might indirectly help with the blood pressure. What happens after you've gone, you know, A, C, D? What's next?
So providing that she can't have a beta blocker for whatever reason, the spironolactone has the most evidence. or lowering blood pressure, I would say, personally. I don't know.
Yeah. I'm just being left field thinking here. If we gave a bit of pranolol for the migraines.
Yeah. But pranolol won't really reduce your blood pressure that much, is it? And I mean, it doesn't have as greater blood pressure.
Yeah.
It's a lipid. It crosses the blood-brain barrier, doesn't it? Pranolol, whereas the others are all water-based, hydrophilic, lipophilic.
Maybe season them on it anyway. Who knows? All right. Any other points or questions before I hand over to Mohammed?
Imran, just thinking broadly, since this is an SMR, somebody pointed out earlier about aspirin. What's the indication for aspirin here? I don't think we have quite covered that.
So, we have PDA.
She's got PAD.
Yeah, PAD would be an indication, wouldn't it?
Yeah. Yeah, it would be.
And also lansoprazole. I haven't checked whether she's having any dyspepsia, etc. Nothing inherently. Okay, it's just aspirin.
It's probably, Mohammed. It is what it is. You take the aspirin every day. Here's some lansoprazole every day. I expect that's what it is. I expect, but we would have to question the patient on that. I mean, that happens regularly, right?
Mm-hmm.
Yeah, potentially without any dyspepsia, etc. There's a potential for reducing polypharmacy.
Yeah. Well, at least count our blessings. It's not 30 milligrams.
I was thinking that. I was like, it's 15. Just leave it. Leave it alone.
And maybe it's the Lanso and the metformin together that's preventing her increasing the dose of metformin potentially due to the stomach problems.
Yeah. Anybody, any thoughts on the lansoprazole? Anything else? Any other thoughts on it?
We haven't discussed compliance at all, Imran. I think when you mentioned that there was a few missed doses, so that's something that's perhaps the elephant in the room that, you know.
It's the occasional missed dose, but she says she always takes them. And you have to take her word for it because the EMIS usage seems to confer with what she says.
The only thing is she might, you know, the GI upset, depending on what it is with the lansoprazole. Don't know when it was, how long it's been going on for. If it was around about the same time, that's the only thing with the when you said about lansoprazole.
Yes, that's true. We can, absolutely. I mean, it could also have been because the patient does get dyspepsia type symptoms. Unfortunately, the South Asian diet can be quite spicy. So I think it's worth.
Metformin?
Sorry?
Is she taking a metformin with food? Because it didn't say. Right.
So again, that's all part of this SMR, isn't it? Let's check. Is the patient taking the metformin with food? Unless we ask, we don't know. And you know what? Sometimes I always say with food with metformin. I never say with or just after food. Because one time I asked somebody and they said, yeah, I take it just after food. And I went, what, immediately after food? You know, 5 minutes, 10 minutes? They went, no, 2 hours, 2 hours later. But for them, that was just after. So, you know, let's say with food, it gives that problem. Okay, I think that was really good. The key thing for me was that, you know, we've recognized that the statin dose, we do need to look at that in terms of coronary disease, because if you've got peripheral artery disease, it's the same as having ACS. You do need to be on a higher dose of statin. This patient has got a high Q risk. I think the Q risk was 26, 27% off the top of my head. They've got high blood pressure. They are diabetic. You know, that risk for a heart attack or stroke is there, and there is history, family history. As you can see, father had an MI, brother had a stroke quite early on. So that's important. This is important.
Can I just
seeing if, go on.
Can I just add two things? So obviously, I know we've got a Q risk here, but we wouldn't use a Q risk on somebody who's already got a statin already, because Q risk is not validated for when we already initiated treatment. And then also, irrespective of her Q risk, she's got the risk factors for a statin. So we don't necessarily need a Q risk in this patient as well.
Yeah,
and then
absolutely. They have established CVD.
Exactly.
So you
And then-
need to be on.
Exactly. And then also, you know, not leaving the statin. So we're wanting a 40% reduction in non-HDL cholesterol.
Right.
And that's what we're
Rima?
aiming for. Yeah.
Yeah. That's going to get covered.
Excellent. Excellent. Perfect. I
That
thought you had a
will
plan
get-
for that.
Yes, we do. We do. All right. Okay, brilliant. I think you're all done very well on that one. I'm now going to hand over to Mohammed. And
Not quite, Imran, because you're still going to operate the slides. Thank you very
Yeah.
much. So I'm going to
No
need a
worries.
little bit more interaction because there was a lot of intervention from Rima. Here we're going to need the whole team to engage. So if you don't, I'm going to name and shame, actually. I won't be as kind as Imran, actually. So let's check. Let's see who has not spoken at all, actually. And I think we'll have to pick on those people. So please speak before you get picked out at, okay? We'll let you off if Rima is going to make a list of everybody who has not spoken. So anyway, this is a much simpler one with a slight caveat. So we're talking about a male, Caucasian, 80-year-old, past medical history is simple. It's just COPD since 2008 and AF since 2019. So Imran, sorry, we'll ask you to move on to the next one. Right, medications, again, quite simple compared to the previous ones. Hopefully you can all comment on this. Relvar Ellipta, the instructions say 1 puff a day, but the patient has 2 inhalers issued every month. Salbutamol MDI inhaler, instructions say 1 or 2 puffs when required, up to 4 times a day, but the patient has 3 inhalers every month without fail. Edoxaban, 60 milligrams, 1 a day, 28 issued monthly. Lansoprazole, the ubiquitous lansoprazole, 30 milligrams OD, 28. And variable repeats are prednisolone 5 milligram, 2 a day, 20 tablets, issued 5 times in the last 12 months. And then you got clarithromycin, 500 milligrams, 1 twice a day, 14, issued again 5 times in the last 12 months. So we'll move on. Thanks, Imran. PMI 28, nothing spectacular. EGFR 62, creatinine clearance, FBCs, LFTs, TFTs, nothing to report there. MRC score 5. That was taken in July 21. And oxygen saturation 95 in July 21. So going on, Imran, thank you very much. Okay, so patient's concerns are he's always breathless. The inhalers are not helping. And he's taking 2 puffs of the Relvar, although it says 1 puff, and he's taking 3 puffs of salbutamol at a time, and he needs it 6 or 7 times a day. Only the prednisolone helps. Can't he just take it all the time? When he's on prednisolone, he feels great, actually. And at the moment, because the doctor says you should only take it when you really get breathless, he only takes it at that time. But he has got little or no phlegm. So there we have it. What would you do? What else would you try to find out? Any thoughts? And remember, I'm going to pick on people if we don't get a response actually from anybody. Yeah, so patients complaining, very breathless. Can't they just stay on prednisolone all day long so that the breathing is much better and the MRC score is 5? What would you do? Right, so I can see there's something on the chat. Patient needs a SABA or optimized inhaler to a combination dual therapy. Does he really need ICS? Okay, see if I can find that on the, is it ACOPD or COPD? Right, okay. No history of asthma at all. The COPD only started since 2008. No real sort of suggestion that there could be asthma today. Yeah. So I will not answer the question about optimizing the inhalers yet, till other people have suggested something. So we've got one suggestion, combination dual therapy. So can I just check, Rehanaz, if you're going to go to a combination dual therapy, do you mean ASABA and ALABA? Are you sort of ALAMA and ALABA? So are you suggesting you discontinue the ICS LABA? Are you suggesting the patient goes on to ALAMA LABA and discontinue it? Yes, okay. And how would you discontinue the ICS? Just switch? Just take off the ICS and just go straight to LAMA LABA? Okay, there's a question which says, what is the patient's eosinophil count? Okay, it's within range. It's say 200. Yeah, there isn't a high eosinophil count.
We don't have a smoking history.
Yes, okay, so yeah, very good point. Okay, that wasn't put on. So patient was a smoker for 20 years and then stopped smoking in 2008 when he realized that he had COPD.
He's on, for his rescue antibiotic, there's an interaction with his DOAC, like it's because he's taking macrolide.
Right,
So,
okay.
I mean,
right.
If he is using it, if the doctor did want to use it, then wouldn't he use like an alternative rescue? I mean, if he decides to use one, would you not use a macrolide? Wouldn't you use like if he's using a broad spectrum, wouldn't you use something like doxycycline instead of a macrolide if you're on like a DOAC, like a doxaban?
Yeah, the reality he's not allergic to penicillin, so he should be
like
on
doxycycline or something.
Should be on amoxicillin or doxycycline is first.
I think doxycycline is the one to see if they're on the DOAC. Yeah. If they can't.
I'm not sure how strong the interaction is between clarithromycin and doxaban. If anybody wants to come in here, but point taken.
Yeah, yeah. I mean, it's what I used to see. They used to just be like, oh, we're not going to give macrolide, we'll give doxy.
Okay, right. Yeah, that's a good point. Thank you very much. Anyone else? There's plenty to comment on here, plenty. So far we have a suggestion of using ALAMA LABA. I still haven't heard an answer as to whether we should just switch from the Relvar, which is an ICS LABA, to a LABA LABA. Haven't had any other suggestion. There's a suggestion about needs a SABA, so the patient's already on the SABA, which is the salbutamol. Come on, there's plenty to talk about here. We're gonna have to start picking on people, surely. MRC. Surely, there's some very obvious things we should be doing here.
Yeah, I mean, his MRC score is quite high. Any pulmonary rehabilitation being offered, up to date with his vaccines. I'd be interested in doing something like Trilogy or Trimbo, something like that for his COPD.
Okay, so you would use Trilogy or Trimbo, and why would you use those?
I mean, I would look at the history. I want to see, has he tried, LAMA in the past with LABA? I'd just be interested in his history. And if he's had some improvement with ICS, why not triple therapy? But I think respiratory secondary care should be involved at this stage as well.
Okay, so you would actually consider bringing in secondary care, right?
I think so. Is his vaccinations up to date?
Okay.
You said smoking's stopped for a long time, so that's good.
Yeah, I mean the vaccinations is great. Yeah, I think that's a very, very good point.
Yeah.
Secondary care we can consider. We'll come back to that one actually. You're considering Trilogy or Trimbo. Which one would you use, Trilogy or Trimbo?
Trilogy.
Okay, you'd use Trilogy. Any reason why you would choose Trilogy?
One of our practices favorites for COPD.
Practices favorite. Okay,
yeah.
That's fine. Thanks for being honest there. And thanks for, anything else? Any other thoughts?
Mohammed, can I ask a question?
Yeah, of course.
Yeah. Can you use the Relvar?
Can you use?
Can you use the Relvar properly?
That is the key question, Imran. That's what I was looking for everybody to tell me. Inhaler technique. Nobody has asked that question so far. We are going into switching the medicine, but nobody has asked the question. is he using the Relvar properly? It's a good question. That would be the first question we would be asking. Is he using it properly? Yeah. Anything else that's very obvious? Now, Imran's not allowed to ask this unless nobody else offers. I can see that somebody suggested add a llama. Okay, that's a reasonable thought. But yeah, we want to check whether the patient's using their Relvar properly. So anything else? Something very obvious that you should all be thinking about. Linked to what Imran said. Come on, surely.
If he's using the salbutamol MDR, we could give a spacer with it, which might improve.
Absolutely right. Not only give a spacer, must absolutely give a spacer. That has to be the case. And there's something else linked to what Imran has said and you have said as well. Tahira, thank you so much for pointing this out. There's something else we need to do besides giving a spacer as well and checking that they're using the Relvar properly. Connected to it. You might think it's already been said, but it hasn't been said. Flow tone, okay, so we've got flow tone. Okay, so thank you very much, Deepak. Why would you use a flow tone? Yeah, thank you very much for the suggestion, but why would we use the flow tone? Perhaps to check technique, yeah? Yes, we want to check the technique. So the two things before we go ahead with any inhaler changes, any switches, anything else, the first thing is to check the technique. And believe it or not, this is a real patient. And what happened in real life is that the nurse had in fact made a note, check technique, but it wasn't very convincing. And effectively, the patient's technique had not been checked. So what is the thing about Relvar that you would be looking out for actually? There's something specific. So salbutamol, you would be looking at the technique to see how the technique is. You could use a flow tone to see if the technique's proper, but whatever happens, if this patient has an MRC score of 5, they're not going to be going out of the house. So there's absolutely no reason why they should not be using a spacer. So absolute must that they must use the spacer. We're not going to give them any more prednisolone till they use the inhaler properly, and you watch them use it properly. Okay, so that's
Psych has put in what you're looking for.
Yes, absolutely. Yes. So Psych has put in inspiration rate. So what is the thing? Why would we be looking for inspiration rate with Relvar? What is the significance of inspiration rate with Relvar?
Is it because it's a dry powder inhaler, so you want it to make sure that they're breathing in quickly and deeply, which is obviously different from the salbutamol, which would be slow and deep, so that they're not using the same technique for both.
Superb, Abida. That is absolutely superb. You would be looking to see if they have enough inspiration to be getting this Relvar in the lungs, basically. And what would be the best way of doing it? How would you figure out if the inspiration was good enough to get it into the lungs effectively?
I don't know if this is related to the inspiration rate, but we can use an in-check device just to see which inhaler would be the best, that IPMDR or DPI.
Yeah, you're absolutely right. Yes, you would be, because you could observe them. You could naturally see them. And if they're taking a nice deep breath, there's a good chance that they'll be getting the dose in. But the classic way is you would actually get an in-check and actually make them do it. Now, I know there are problems with getting it at surgeries, etc., but there's nothing better than using the in-check device. And actually, this is a real patient, use the in-check device on them, and it came up with a reading of 30 on the resistance of the Relvar. Now, Relvar doesn't give you a feedback, so you don't know if the patient's really taken it in or not. Yeah. And what is the other thing about Relvar? That it is the dose. The dose is considered a great thing, that it's once a day. But what is the problem with once a day dosing?
If he's only getting half the dose, it's a once a day. So if it was 2 puffs, for example, of something else, at least he'd get more of a chance of getting the medication in. He's only got one chance.
Well
to get
done. I don't know whether it's Tahir or Aksa, but that is superb. Because, yes, it's great having 1 puff, but what if you were just to go, which is what this patient was doing, actually doing it and going, that's it. I've done it. Oh, wonderful. I've done it. There's no feedback. There's nothing. I've done it. And when you actually check the inspiration, you notice that it is 30. So And that is when you actually ask the patient to breathe it in deeply. So without asking deeply, just go, and that's it, done it. So that was not very useful actually. Now with the salbutamol MDI and with you give a spacer, what would you advise when you a COPD patient who has got an MRC score of 5? So what is the inspiration rate going to be like? We already discussed it. It's very low. Yeah, it's very, very low. So what advice would you give them when they're using the salbutamol with the MDI? Tidal breathing. Well done, Anita. That's absolutely superb. That's one thing you really have to get across to them. Use tidal breathing, because one puff, even taken deeply and gently, how far will that benefit? Whereas if you're using, and the classic thing, what you want to show them is, I mean, the key thing I tell them is, look, it's for deep in here. You want to get it in here. This is your lovely friend that's holding it for you. And effectively, what you want to do is you want to take in 5 nice deep breaths. So you can actually feel it in your lungs. And that normally gets them going and makes them want to do it properly. And again, this is a COPD patient who's going to be at home anyway. Now, as far as the Relvar is concerned, so okay, so we've got a scenario where this patient has got inspiratory flow rate of 30 with the resistance of the Relvar. What would you do in those cases? And you need really 60 plus to get a proper dose of DPI in. It's once a day as well. Now, given this, what would you do? What would you continue with the Relvar? Would you replace it? Would you do something with it? Nobody? So we had an offer of using Trilogy. Problem with Trilogy here is it's again once a day, same resistance as the Relvar, and the patient's clearly not got enough inspiration to breathe it in. So here we would have a choice. We could possibly change to a LABA/LAMA. Problem with that is you're taking away the steroid all of a sudden. Probably the patient isn't getting a lot of steroids, so possible. The other way is to go for triple therapy. You don't really need to refer to secondary care for triple therapy unless you had a particular reason for doing that. So which are the perhaps use an MDI then in that case? So what would be the choices then? So assuming Relvar has not got enough inspiration, Trilogy won't have enough inspiration for it, what are the choices? So what are the choices within MDIs that you would go for?
Why not try Foster twice a day?
Mm-hmm. Right, so you would try Foster, okay, fine, as an MDI?
Yeah, as an MDI with the spacer.
Yeah, that's definitely a possibility actually. The one thing that you would think about is that there's very much a benefit from a LAMA in COPD. And I would be tempted because of that. And you are having the ICS already. Withdrawing the ICS as a sudden drop, I would be thinking more triple therapy. But again, you're right. It is perfectly feasible to use Foster. Problem with adding another LAMA is that then you would have 3 different inhalers and already the patient struggling to use them properly. But point taken, it's a valid point.
Mohammed, could we not go exactly what Dipali said, is because the sort of usage of the Relvar is really poor. And potentially, I'm just thinking, if we use something like a ICS LABA MDI, whichever one, right? Use that for a few months. And if the patient's still not well-controlled, MRC still 5, then go triple. Is that possible? Yeah, triple with MDI?
Fine. Perfectly fine. Yeah, I think there's a 50-50 decision here. You could go for an ICS LABA like Foster, and you would go for it and try it out using the spacer, or you could go for triple therapy in this case. And just looking at, so if we went for triple therapy, what would be our choices? What would anybody use? We had
For me, for me, anyway, if no one else wants to jump in here, I would be going for Trimbo because of the inspiration rate, and give them and spacer with that as well.
Yeah, and then it ties up with the salbutamol as well in terms of technique, using one technique. The other advantage of Trimbo is it's 2 puffs twice a day. So if one puff is not great, you have the possibility, and the patient's already using 2 puffs anyway. So that's something well worth. There are other options now as well, so that we are seen to be completely balanced. There's Trihixio, which is also available now from AZ, which is also an MDI. It is also 2 puffs twice a day, so that's a possibility. Now, because this patient has low inspiration, there's one other possibility that we could use as well, besides an MDI. Again, just being fair to all the different options that are out there. Anybody want to? Sorry?
A Respimat device?
Yeah, slight problem with the Respimat is that, again, it's not available as triple therapy. It'll be either a LABA-LAMA. So we could take the patient off the ICS and just put them on Spiolto, LABA-LAMA. So that is a possibility. Potentially one other possibility would have been a Breezhaler, which is a DPI with very low inspiratory capacity required. Having said that, at the moment, whilst they've launched a triple therapy, it's called Enazair, it is not licensed for COPD, licensed for asthma only. So really, the choices are either using Foster as an MDI, or potentially going with either the Trihixo or the Trimbo as a triple therapy as an MDI. There is also Trimbo Nextale available, but that has even higher resistance than Ellipta. So that has to be taken into account. Anything else anybody else have anything to say on inhalers before we go on to 2 other things that we haven't quite noticed? Prednisolone. What is interesting about prednisolone?
The steroid dose isn't quite right, is it? 10 milligrams a day.
Yeah.
And
just
also,
2 a day.
Yeah, and do they understand how to use their rescue pack, and when you use a steroid and when you use an antibiotic? Yeah.
So if we go back, Imran, in terms of, or we might go forward. And okay, so this is the key thing. When does the patient use the prednisone and the clarithromycin? When he gets more breathless, but he's got little or no phlegm. So firstly, the dose of prednisolone is completely wrong, because it should be starting off with, it should be 7 a day for 5 days. The other thing is that, or 5 a day for 7 days, whichever way around you choose. Also, if it's just breathlessness, then potentially, hopefully, we'll have now the salbutamol being used properly. So you could just up the salbutamol in the future with the spacer, or just use the prednisolone by itself, because there's no effect on the phlegm. Potentially, it's not an infection. Yeah, so that's something that could be considered. Yeah, anybody have any thoughts on that before we go on to the other bit? Patients on edoxaban has AF, is feeling breathless all the time. Could there be something else?
Should we be checking for heart failure?
Yeah. Also, the AF, it's only controlled with edoxaban. There is no beta blocker. There's no rate control. Could it be actually palpitations? Could it be that's causing some of the breathlessness? And it could be a lack of rate control in the AF that's potentially leading to the breathlessness. So that's just something, and heart failure as well. So potentially looking at that and looking at it holistically. And then sorry.
Oh, I was just going to say, before you move on to the heart failure, I would have talked about a patient plan, like a written plan for the patient. And
absolutely. Yes. A COPD action plan. Well done, Rima. Absolutely right. Yes, definitely. That would be including when to take the prednisolone and when to take the rescue packs. and to use the MDI better, etc. So definitely, yeah, written action plan would be great. Absolutely right.
And the other thing I was going to say was, I mean, in practice, I also do like a COPD assessment test. So that just tells you how they're doing in terms of their day-to-day life, rather than the MRC doesn't always give you how they're managing in life.
A CAT score. Yes, you're absolutely right. CAT score should have been part of it as well, actually. Yes.
So it just gives it, because you may not want to escalate treatment always based on your MRC score.
Totally agree.
Because the old guideline, well, in our area anyway, if you have an MRC of greater than 4 and 5, you are dealt with by the specialist team. It's out of our care once it becomes 5. But you know, if they have a good daily activity thing, then why wouldn't you manage it in practice rather than specialist team?
To be totally honest, this patient was given Trimbo and got a lot better.
Yeah, I'm sure.
and was quite happy actually, and the MRC score was improved. Everything was improved actually. It was just a case of not using the inhaler properly, and nobody had really gone in and checked that the patient was using the inhaler properly. A review had been done by the nurse, but I wasn't confident that the technique had actually been checked. And it even said technique checked, but it had not been checked. And you notice that time and time again. I would strongly suggest if you're doing an SMR with respiratory, you actually check how the patient's using the inhaler. And that gives you so much more information than even if somebody else has carried it out before. Had a situation with somebody using the breeze-hail and not even getting the noise from it, getting absolutely no benefit out of it. One more thing, anybody else? Thanks, Rima. That was very, very helpful. There were things that I'd written to mention, which I did not. So thank you very much. Anybody else? Anything else with the medication? Imran, if you could just go back to the medication. Thank you. Yep. No, actually, thanks for working it so well, Imran. You're a very able assistant, actually. Anything else regarding the medication? Has everybody had enough now?
I guess it's about the steroids as well, isn't it? And the risk of osteoporosis with constant sort of steroid use, and also being on lansoprazole.
Yeah. And anything else? Lansoprazole? Really needed 30 milligrams of lansoprazole?
Yeah, need a review on that dose. Yeah.
It's the most common medicine we find, actually. It's I think anybody going out of hospital comes back with lansoprazole, whether they have had any indication or no indication, and is there really an indication for lansoprazole?
I'm just going to say the other big thing, it would be a steroid card would be needed to be issued for someone who's had lots of prednisolones.
Yeah. Good point. Hopefully, I think in the last 6 months, the patients had none since they were changed over. Actually. But yeah, good point in terms of.
And I think it's already been mentioned, but it can't be clarithromycin if you're on a doxycycline. It has to be doxy.
Yeah, I would say that doxycycline.
Yeah.
Any other thoughts? Yes, thank you all very much.
Thank you, Mohammed.
Thanks,
Thank
Imran.
you. It's very good.
That was brilliant. Thank you so much. I learned quite a bit there. Thank you. Okay, so as I said before, if you're Redbridge, please can you stay behind? If you're not Redbridge, you can still stay behind because hopefully we'll be doing this right across BHR. But initially, what we're doing is we're doing a project